Ladies and gentlemen, thank you all for attending these sections. This section is the ELSA and APMBSS bariatric sections. My name is Dr. Simon Wong from Hong Kong, and today I will co-chair with Dr. Raymond Goh. He is the bariatric and metabolic surgeons in Hadajas Healthcare, and he will be with us for this section as well. Hi, Raymond.
Yeah, hi. I'm back.
Good.
Was really a leap of faith.
All right, so you can introduce our speakers.
I
introduced you already.
You've already done that. So I start with my presentation.
Yeah. Oh, yes, you are the first speaker. Sorry. Yes, our first speaker is Dr. Raymond Goh, and he's going to talk about impact of COVID and impact of COVID on the obesity and diabetes.
Hi, morning, friends. So when this topic was given to me by Simon, I was wondering, it's not a surgical topic, but then as I read about it, I realized that there is so much to learn from the data which is available. And so I'll try to show you. I have no disclosures about this topic. And the issues that we are going to cover is that there is enough evidence which is evolving now, which shows how the obesity and diabetes are related to COVID, or is it a cause or the effect? And what is the impact of diabetes comorbidities on COVID outcomes, and how we can apply this knowledge on bariatric practice. So I hope in next 10 minutes, I should be able to cover this. So starting with diabetes, this has been established that, because of the altered lifestyle, anxiety, disturbed sleep, there is a significant impact on diabetes control, and also because the services are not available. And because the services are not available, there is a compromise in care of diabetes. And challenge is how to prioritize acute care in COVID-19 while maintaining routine diabetes care. So there are enough studies which have come which shows that diabetes is a risk factor of COVID, and I don't need to go through that. But even in SARS-CoV era in 2010, a transient hyperglycemia in patients led to increased mortality. So it's not only a question of diabetes or transient hyperglycemia. And now we have this data from New York City, which is showing that there is a increased number of patients, and it's one of the commonest comorbidity in hospitalized patients. Now, diabetes and COVID, there is a higher risk of infection and severity of COVID-19 in diabetics. This is, most of us are aware. And this is what the perception was, that more people are getting infected because they are diabetic. And then their viral infections lead to severity of symptoms and complications. There's another factor that there are many patients who have undergone a solid organ transplantation because of diabetes-related issues. And then they are on immunosuppression, and that also is leading to increased risk after in COVID. Now, but recently, in last 6 months, as more analysis has started analyzing diabetics who are under COVID management, it has been found that even well-controlled type 1 diabetic persons are not at higher risk of COVID infection. And then there is another study which got published later, which says risk of contracting COVID-19 may be no greater in diabetics. So primarily what we are trying to differentiate, the data is differentiating, is that the risk of getting infection is not higher in diabetics. So what is the issue involved? So the issue is that once somebody has a COVID-19, there is an increased insulin requirement to maintain blood sugar, and there is a slower clearance of virus in diabetics. So we have heard reports that people have positive RT-PCR even after a month. And now this is seen that diabetics are the ones where those reports may remain positive. And there are various mechanisms why this is happening in diabetics: chronic inflammation, impaired immune response, increased coagulation activity, and direct islet cell injury from COVID-19. Now the researchers are differentiating in diabetes versus hyperglycemia. So what the recent research shows, that well-controlled diabetes is associated with better outcome than poorly controlled diabetics. And it's not a question of diabetes alone. Even short-term hyperglycemia can stun the innate immune system. We know most of the COVID patients are now kept on steroids, and they may have a hyperglycemia. So it's important to maintain their hyperglycemia, the blood sugar levels, otherwise their immunity is further compromised. And acute hyperglycemia is a greater risk factor for adverse outcome than just a diagnosis of diabetes. Then there is a very interesting meta-analysis of 8 studies with 46,000 patients which got published, where they said that odds ratio of severe disease is not higher in patients with diabetes, unlike those who have diabetes-related hypertension and cardiovascular disease. So diabetes complications and comorbidities are associated with a higher mortality rate than the presence of diabetes. And there are now various studies which are showing that there are worse outcomes in the elderly. We all know that, but it is probably because they have a long-term type 2 diabetes and related comorbidities. So primarily from diagnosis of diabetes, now we are talking of uncontrolled diabetes and diabetes comorbidities, especially hypertension and cardiovascular disease, where they are associated, the risk is higher. Then what about the diabetes medication? It has been seen that there is an increased risk of ketoacidosis in COVID patients, and SGLT2 inhibitors, where they are being given, there is a higher risk of ketoacidosis. So most of the physicians stop SGLT2 inhibitors at the time of admission for COVID management. Metformin and GLP-1 has not been directly implicated, but it has been said that they should be used with caution, and the preferred treatment is insulin, because it also has anti-inflammatory effect. So most of the patients should be preferably kept on insulin for COVID management and diabetes management. So closing the diabetes part of it, diabetics are not at higher risk of COVID infection. Uncontrolled diabetes leads to increased severity of COVID. Complications like hypertension and cardiovascular disease have higher mortalities. They have more severe COVID, and SGLT2 inhibitors should be avoided and insulin should be preferred. So this is the learning that we can carry home. Now moving on to obesity and COVID. Now we all know that obesity leads to increased free fatty acid, insulin resistance, hypertriglyceridemia, metabolic syndrome, and obesity is an inflammatory state. So it leads to hypertension, atherosclerosis, and even thrombosis. So this is primarily there, what is also seen in COVID. So they both join together, and obesity leads to impaired immune response, even with other viruses and influenza. So in COVID, then definitely it's one of the factors. Now, obesity, as we already know, leads to respiratory issues and more invasive ventilation, more obstructive sleep apnea, airway obstruction, hypoxia, and increased intra-abdominal pressure leads to impaired lung function, increased risk of desaturation and intubation. Now, all this was already known, and it has been highlighted in recent studies of COVID-19. So they actually become synergistic when COVID-19 comes. So now there are multiple studies which show that obesity is independently correlated with increased intubation risk and mortality when the patients are controlled for age, gender, hypertension, and diabetes. Now, one caveat that I would like to tell is these studies are published at different phases of pandemic. So I'll show you some larger studies which go against this data later. Now, obesity increases risk for COVID-19 complications in young, yes. It has been seen that those who are 45 to 64 years and they have obesity, they have a relative risk of 3 for intubation compared to those who are a normal BMI, and even those who are more than 65 BMI, their risk of intubation is 2.1. So a young person with obesity has a higher risk of intubation requirement than an elderly person who is not obese. So this is, and those who are under 60 years patient who are obese are more likely to require critical care. And this has been seen in many European countries where the obesity rates are higher, that the once the patient falls sick, the deaths are higher. Then we all have heard that male gender is an independent mortality predictor. Higher mortality and risk of intubation in men with obesity compared to women. And probably it's because of higher visceral fat in men. They have more inflammation and they have raised CRP, and these have come in various studies recently. Now, this is a very interesting study which comes from UK. So this study has evaluated almost 2 million population through the electronic health record. And they found that just about 250 to 500 deaths happened, extra deaths happened due to COVID-19 in severe obesity. And this is less than those who had two illnesses. So here again, just like diabetes, comorbidity is playing a bigger role than the diagnosis of obesity. And they say few excess deaths are associated with severe obesity compared with overall obesity. So when we hear this news that obesity leads to more deaths, that is true. But as far as severe obesity is concerned, it is not an additional risk factor, because hardly 250 to 500 deaths happened. And I'll show you another study. So in UK, they analyzed the primary care data of some 5,000.
Excuse me, Raman.
Yeah, just last two
yeah.
slides. Yeah.
Thank you.
5,700 COVID-19 patients, in which 1,600 deaths happened in non-severely obese patient, only 216 severely obese patient. And there's another UK intensive care audit where they said 7% patients were severely obese and 31% were non-severely obese. So going back to the previous study, they said that there is more risk related to lockdown. Just because there was a 3-month lockdown, the population which should have grown obese by 98,000 on an annual basis would probably grow to 434,000 because of 3-month lockdown. And this is likely to lead to more deaths from COVID during next 1 year. So I think lockdown itself has a major problem in obese. So to conclude, take-home messages are: obesity increases intubation and mortality risk. Obesity increases risk among young and men. Overall, severe obesity alone does not increase mortality risk. This is something that has to be analyzed further. Health intervention should be targeted at comorbidities associated with obesity, as in diabetes, which are determinant of the excess deaths. So obese people do get admitted more, or more deaths happen in those who have at least 2 associated comorbidity. So applying this knowledge on bariatric surgery, I think there is a lot of information coming in. This evolving knowledge is a challenge to any attempt in prioritizing bariatric surgery during pandemic. I think we need to wait to decide to create a protocol how bariatric surgery should be done during COVID-19 time. Thank you so much.
Thank you. Thank you, Raman. Because of the time, we will go straight to our second speaker. Thank you, Raman. So we will introduce Dr. Mahai Osman. I think Professor Osman, no introduction. He's a famous laparoscopic surgeon from Turkey, and he is the graduate from the Ankara University Medical School. And he's currently the professor of the Department of Surgery in Istine University in Istanbul. So today he will going to share with us his experience in the COVID in Turkey. So Professor Osman.
Thank you, Simon, for the introduction. I'm gonna try to be in time, and let me share my screen. Okay, can you see the screen now?
Yes, good.
Okay, let me do this. Okay, today I will try to summarize the effect of COVID-19 on bariatric surgical practice around the globe. And if I can just change the screen, I cannot
You will have to click twice.
I have no disclosure. And COVID-19 emerged in Wuhan, China, as you all know, in December 2019. And it is thought to be a beta coronavirus related to the SARS virus. COVID-19 infection run the spectrum from asymptomatic disease to severe acute respiratory infection, and the lacking the herd immunity and in the absence of effective vaccines or antiviral therapies, countries like Turkey, India, and all around the world are witnessing an unprecedented strain on health systems and disruption of economies. If we look at the clinics of the COVID-19 infection, 14% of the patient will develop severe disease, which requires hospitalization and oxygen support, whereas 5% will require admission to an intensive care unit. For those 5%, sepsis, septic shock, multi-organ failure, including kidney injury and cardiac injury, might all occur. And as you already mentioned, older age and comorbid disease have been reported as risk factors for the death. And the prevalence of the diabetes was 20% and hypertension was 30% in the first cases analyzed for the risk factors. And if you look at the COVID-19 risk in persons with obesity, and by virtue of the increased risk of chronic disease that obesity drives, the risk is expected to increase in that group of patients. And the Center for Disease Control and Prevention considers those with BMI over 40 being at risk even for flu complication. So we can say that obesity is a main risk factor for comorbidities such as diabetes, hypertension, cardiac problems, metabolic health problems. I believe obesity shall be an independent risk factor for the COVID-19 and its complications. If you look at this diagram, you can see that obesity causes respiratory dysfunction, which results in changes on pneumonia and pulmonary hypertension and cardiac stress. And also obesity causes comorbidities such as diabetes, cardiovascular disease, kidney disease, which also result in increased vulnerability of patient to pneumonia-associated organ failures. And we also know that the risk of metabolic problems in patients with obesity might result in cardiovascular events and increase susceptibility to infection. Altogether, actually increases the severity of the COVID-19 infection. If you look at the numbers from yesterday, 28,500,000 people are currently infected with coronavirus, and around over 900,000 deaths all over the world. And currently 60,000 patients are actually serious or critical in ICUs all over the world. So this pandemic will affect all walks of medicine. The impact on bariatric surgery, I believe, will be much harsher because it is rather flagelling nature in many parts of the world, conscious and subconscious bias against those suffering from obesity, and anticipated financial constraints in the future, and significant technical expertise needed to perform bariatric surgery. I will come back to this. We should start thinking about resource allocation, training needs for the youngest surgeons, and the shape of the future services to be fully equipped. And when we come out to the other end at the end of the pandemic, so we can actually deal with the problems of the obese patients. Elective bariatric surgery, as you all know, has come to gritting halt during this pandemic, especially in countries with a long waiting time, such as England, UK, USA, in some European countries. And less than 0.6% of patients are actually eligible for bariatric surgery with a nice criteria in UK. That's why we can say that COVID pandemic and the obesity is a global pandemic, so we can call it as co-obesity. And we know from our experience that, as well as that of others, a large number of patients needing intensive care after COVID-19 infection suffer from overweight or obesity, are more likely to die after COVID-19 infection, as the previous speaker said, because of the nature of obesity and immune changes caused by obesity itself. So the waiting time and its clinical consequences are associated with an increase in morbidity and mortality of COVID-19 pandemic. So bariatric surgery has a significant learning curve, as you all know, and there will be a risk that when surgeons are not able to operate for months, not weeks, for months, so they might actually de-skill. So this will apply to all surgeons, those who perform technically demanding operations, and those still within their learning curve will be more severely affected. If we look at the solution to reduce the rate of errors and enhance the overall safety of the procedures, so it is important that surgeons should keep up with their skills by video webinars and congresses like this one, and thanks to Asim and all the organizers, and technical discussions virtually. And it may also be necessary even for consultants to scrub together for the first field case, as suggested by a paper by Mahawar and Hussein for a couple of months ago, in order to decrease the rate of complication during the surgery. But I believe, based on this finding, shall we stop surgery? I believe we don't need to stop surgery, but we have to adapt our surgical practice to COVID-19 infection. There are many papers published, including ours, including recommendation by ELSA and recommendation by other societies like IFSO, EASO, and other organizations. When we look at that paper, and also one paper published by Mahawar et al., in which I'm also involved, looking for the consensus statement, including 44 experts from all over the countries around the world. And I will go through that in a minute. But what is new in the preparation of the patient? We cannot actually get the patient to the theater without having PCR results. And we also need to get IgM and IgG before the procedures. And if it is necessary, your patient needs to have a thorax CT scan. All of them are not actually in the algorithm of the preparation of the patient for the obesity surgery. So appropriate PPE is part of our daily life, as recommended by all the societies, in order to decrease the risk for the staff and the operators. And an ERAS program, which were being discussed generally in all over the world to use commonly for bariatric surgery. I believe after this pandemic, ERAS might be a solution in order to decrease the hospital stay, just to keep a reserve bed for the patient with the COVID-19 infection. So one paper is published by Rubino et al., and which is summarizing what we will need to do before surgery and after surgery, and also how we can manage patients who already had surgery during COVID-19 pandemic. As you all know, because of the lockdown, patient will have difficulties in reaching treatment, in reaching to surgeons. So telemedicine is going to be the part of our lives. So this is the paper we published, including our general arrangements during COVID-19 in operating room practice. And also it's published by ELSA and EAS, and also some societies in UK, Royal College of Surgeons, what we need to do before surgery and during surgery if we are using laparoscopy or robotic surgery in order to decrease the rate of COVID-19 infection. This is my colleague, assistant professor, Emir Güldogan. He is actually trying to show you which kind of equipment we will need during this pandemic, not only for bariatric surgery, but also for all kinds of surgery, including laparoscopy and even the robotic surgeries. And you all know how to do this. I will just keep the video short, and I will go and show you all the equipment you need: liquid-proof apron, PPE containing mask, face protective transparent barrier, gloves of double layer or biobarrier gloves, non-perforated shoes or rubber boots, which can be sterilized, should be used. And air seal is very important. If you have access to this kind of equipment, it will stop the leak of the gas in the theater, and it will control abdominal carbon dioxide.
One more minute, please.
Okay, I will do that. Contaminated with the COVID-19 will be taken by this system. I will not go through on the system, but I can say that SARS-CoV-2 size is small, and we can use smoke evacuators for this system. If you don't have air seal because it's too expensive, don't worry, you can actually make your own air seal, as we are doing here. It's actually 1 minute video, but what we do it, we can use MF line and put them on your trocars, and before you come out, you can actually take all the, either you suck the carbon dioxide, or you can actually get them, desufflate them into the disinfectant solutions like Sidex, which is in this rubbish bin bag. And also that will stop the risk of transmission after surgery. I would like to mention about the study of this consensus statement published by Muhawar team that includes 44 experts from 23 countries. And he asked us 111 statements in 2 rounds. And most of you are actually included in this paper. And we answered about the key consensus point on general and facility-specific consideration, and patient and staff-specific testing, and patient selection consideration, and also operative consideration. So most of us are actually involved in bariatric surgery, already know that what's the result of this consensus. But I can say that, yes, we can carry on doing bariatric metabolic surgery, but we have to take consideration of the changes during patient preparation, and also we have to take a special caution during surgery. The patient needs COVID-19 testing and PCR before surgery, and if necessary, the patient relatives or the representative will, who is going to stay in the hospital, will also need to have the testing for COVID-19. And also, if there is any possibility of contamination, whole team needs to be checked with the COVID-19 testing, so we can carry on bariatric metabolic surgery by using personal protective equipment during surgery. And also postoperative follow-up will require sort of telemedicine and access to face-to-face to see your surgeon. And I can say thank you for this opportunity to present my talk from Istanbul, as you can see here on the Bosphorus. I hope the pandemic days will go away, and we will all meet in Istanbul for the next coming ELSA meeting in the future. Thank you.
Thank you. Thank you so much, Dr. Osman. That was wonderful. We'll take the questions at the end. And it's a pleasure to introduce the chairman of this session, Dr. Simon Wong, who is the president of APMBSS and also the chairman of the upcoming meeting in Hong Kong next year. Professor Wong is going to talk on the third wave, a new normal in public bariatric care. Simon, please unmute yourself. No, you will have to unmute yourself. I can't hear you. Not yet.
Okay, is it better?
Yes, now it's fine.
Sorry. So, thank you for this coming to this meeting. So my job today is talk about our Hong Kong situations. So we all know after the last ELSA, when they come home, and we noticed there's a new virus coming, which is the COVID-19, and it spread quickly around the world. And just in March, the WHO had announced this is a pandemic situation. We are all scared, especially for us. We seem to have a deja vu because in 17 years ago, we have a SARS attack, and this attack to our hospital, Prince of Wales, and only in 3 or 4 months' time, it caused lots of troubles. so scared because we found that this is very contagious with up to 20%, 30% of the victims are actually healthcare workers. And in Hong Kong, it also carried a very high mortality of 17% with this SARS attack. So we all very cautious. And now when this second wave or second disease come from China, we now learn from the SARS that first of all, we need to block or control the imports. And also we need to control the local disease. Controlling the import by the border restriction and also quarantine policy, I think everyone is doing now. And also prevent the local, because local outbreak is the most important problem. And we all know this is a coronavirus similar to SARS, is transmitted droplets. So by properly wearing a mask, it can maximally minimize the infection. So that's why in Hong Kong, very early on, we had adopted this universal masking. And the survey recent, initially you can see up to 95% of the population is wearing a mask in Hong Kong. So by doing that, actually the first wave from China is not too bad. We actually have only 10 cases per day at most in this first wave of attack. And so we feel a bit secure, but we know that we cannot relax because previous study or previous prediction that if you do nothing, these will have a big impact of the society and especially on the medical care. So we need to prepare ourselves, and we don't want our staff to walk around the hospital with a garbage bag for protections. And this is why early on in January, our hospital in Hong Kong has started the emergency response level, which should try to prepare for the surge and also prevent the infection, especially cross-infection in the hospital. Apart from universal masking, we also do the PPE precaution very strictly. And when we try to triage the patient in the clinic or when we don't know the status, we will put this kind of triage, mask on and gown on and glove on. But when you go for truly COVID cases or suspected cases, actually we are putting on all the N95 and ICU and level 3 gown and glove. But we don't put on those AMA type of protection as you seen on Dr. Osman's. But we found this is good enough for us. But for COVID, I think the most important for us is to not just protect the healthcare, but also our patients who are not infected. So that's why we postpone all the clinic and also all the elective surgery. We only perform emergency surgery during the first 2 months of attack. But we know that there is a balance. Apart from emergency surgery, there's also urgent other surgery of cancer surgery, life-threatening surgery. We need to take care. So this is truly balanced. And for bariatric patients, they truly need to protect because for them, they are obese and have diabetes. And as you listen to Raymond, you will know that it's a lethal combination. And with obesity, the chance of being ventilated and go to ICUs is much higher than in the low BMI patients. And also diabetes has significantly increased the chance of being admitted to ICU in this multiple study in China. So we don't want them to catch this disease during the high-risk period. So our strategy is to stop the service at this moment. But on the other hand, this stop is also get us by time to preserve the PPE and get the hospital or the society ready for the attack. Because we know, although we don't have disease, but outside the world is growing very quickly. And when these people come back to Hong Kong, especially those students, they come back to Hong Kong, they will, just like us, lead to the second wave. And this second wave is coming much harder. But we found that if you get quarantine and control, you know where they are, so that if you exclude those quarantine or imported cases, this second wave, actually we can control it by quarantine them and also put all the related COVID positive patients in the hospitals. So we feel that in a few months' time, there's not much cases. We try to start the service. The question is when and how. And we know that if patients get infected in the hospital and do a surgery, we know they will have a higher chance of respiratory complication with COVID. And also with elective surgery, even in young patients, the mortality will go up to 20% if you get COVID during the surgery. So this is why when we consider we start the surgery, we need to consider whether you have availability of the PPE and also the local disease status control. So this is a bit of complicated, but actually easy to understand that when no matter what is the PPE supply and the disease control, you need to provide emergency service. For cancer service or high priority surgery, we need to start it when the reserve is reasonable and when the surge is not as expanded potential as such. But for elective or bariatric surgery, we need to really the disease is well controlled in the society so that the society had enough resources for the others. And that is why during the COVID status, high status, we need to stop, but low phases, we can consider we start. But if so, the recommendation that tell us we need to do something, which is now the new normal, which is screening. I think screening, you don't know, this is either through the history or through testing. History of contact, history of cluster, and history of symptom, of course, we do delay the surgery. But for those without the history, testing is important. We know there are several tests, the PCR tests, the antibody test or antigen test. They have all good and bad on that. But for accuracy, we always try to use the PCR as the gold standards. But PCR also have problem because they are costly. They also take time to test. And also they may cause a lot of burden if you test everybody in the hospital. For example, in Hong Kong, we can only afford for 4,000 tests per day. So we cannot afford to test everyone who go to the hospital. So this is screening with those who are necessary to test. So in this sense, we start the surgery with a new standard, which means that we admit the patient a day before, and then they will go through the screening. And if they are negative, and also we try to avoid those who need, and if they need postpone. And also if they need CPAP, we also need to test the COVID, because that is one of the criteria for COVID testing before surgery. Before surgery, we also do the routine checking and give a consent and tell them their risk of infections. And this is very cautious. They will look for the compulsory COVID testing, whether they are respiratory surgery or ICU status. And then slowly, when they go to the old theater, they will have all ganged up with an N95 protection, and the team will not be allowed to touch other team unless after intubations. When we go into operation, then it should be safe. So actually, our standard gounding is, you can see, is mainly PPE with eye shield. And N95 is not a must, because we know there's a really low risk, but of course you can still wear it if they're available. And smoke evacuator, again, there is no consensus and no evidence that this is useful, so we are not using it regularly. So you can see that the lumbar operation during the lockdown or restriction has significantly decreased to 40%. We maintain the surgery emergency, but the elective is reduced. And for bariatric, of course, we actually stop for 3 months, but gradually we start during the second phase. But unluckily, in January, there is a third phase will come back because we found that there is a loophole in the quarantine because we don't quarantine the crew member or the pilots who work for the transport. And this brings up a high spread rate, which is more than 100 cases per day in that month. And there is a lot of inpatient that we need to take care. So what we need to do is strengthen the anti-COVID policy in the community to stop the spreading. And also we start to do the community COVID testing by the help of China government. And also we try to build enough status to hold the patient with less symptoms. So that's why we convert the expo center into a 500-bed hospital for this grave periods. Luckily, with all this status, we are going down with the cases less than 10 cases per day in the recent 1 week. So hopefully, although we have stopped the procedure for the last 2 months, now we can resume it with the selection, as I mentioned before. So at the end of the day, this is a long road. And with the development of vaccine and also effective treatment, I think that is not that lethal disease. But of course, the healthcare is the most important to conserve. And luckily, in this period, we don't have any cluster infection among by the patients in our healthcare. And hopefully, this virus will go away soon. so that in the next year we can see you all in Hong Kong. We will prepare the conference in April, so that hopefully we will meet all of you there. Thank you.
Thank you, Simon, for a wonderful presentation of how Hong Kong covered the various surges. And since we are short of time, we can probably go ahead with the panel, and the questions we can probably take at the same time when the panel discussion is happening. So I invite the moderators for the panel, Dr. Shabir from Singapore and Dr. Kasama from Japan, to take over the charge on the panel with the title, Bariatric Surgery in COVID Times, How Safe? Over to you.
Thank you, Robin. So from this time, can you hear me?
Yes.
Yes. Okay. So from this time, we'd like to move on to the next discussion. And this discussion will be moderated by Dr. Asim Shabir from Singapore and myself from Tokyo, Japan. And we have 3 panelists on the symposium on discussion. One from the UK, Dr. Vinod Menon. He's a highly experienced laparoscopic upper GI and obesity surgeon in UK, and he is also the honorary secretary of the British Obesity and Metabolic Surgery Society. And the other panelist is Professor Wei Li from Taiwan. He is the honorary president of the APMBSS. And other panelists, Dr. Sintep from Thailand. He is president of ELSA and also the president-elect of APMBSS. First, we'd like to have the presentation from Dr. Menon regarding the UK experience. So Dr. Menon, please start your presentation.
Thank you. Thank you. Thank you for the kind introduction. Let me try to share my screen and can you see me? See my screen?
Not yet.
No. Okay. Give me 1 second.
Sure.
Give me 1 second. Share and
Yes.
yes. Can I can you see me now?
Yes.
Yes.
Good. Good. Excellent. Excellent. Thank you. So good afternoon, colleagues, ladies and gentlemen. Greetings from the United Kingdom and from the British Obesity and Metabolic Surgery Society. And thank you for the opportunity to speak on bariatric surgery in COVID times, how safe, and to talk about the experience from the United Kingdom at this ELSA 2020 virtual Congress. Just trying to move my slide.
Are you in a PowerPoint mode?
Yes, I am.
No, you can click on the slide twice and it will work.
Ah, okay. Thank you. Thank you. So the whole world, as we discussed, is facing an unprecedented situation caused by COVID-19. Several lives have been lost globally and families devastated, and our hearts go out to them. The United Kingdom, too, has had a very turbulent time. The first death, as you can see, noted on the 9th of March, and 2 weeks later, it kind of exploded, and lockdown was declared on the 23rd of March, 2020. And elective surgery was ceased on that day, and bariatric surgery was no exception. 5 months later, the end of August, this country had over 330,000 positive cases, 41,000 deaths. But what is quite reassuring is that over the last few weeks, the numbers have started dwindling and the number of deaths have got far less, which is very reassuring, even though we are also still very worried about an impending second surge. Over the last several years, the United Kingdom has published our data through the National Bariatric Surgery Registry into the IFSO Global Registry And you can see the charts out here. The Royal College of Surgeons of England have been very concerned about the reduction of elective activity. And as we heard from my esteemed previous speakers, the impact on trainees and training. And this most recent publication of the British Journal of Surgery very clearly demonstrated that there was about a 75% cancellation rate for elective surgery of all forms, and this is across the world during the peak 12 months of disruption from COVID. So the British Obesity and Metabolic Surgery Society took real note of this, and it was an uphill task to re-establish elective bariatric surgery, but we remained very committed. And the first step we took was to produce a briefing paper which would appeal to everyone, not just surgeons, but professionals, doctors, general public, and politicians. The UK has a population of 68 million, which 52 million are adults. 32 million have a high BMI, and 14 million are clinically obese. And we heard about from Dr. Osman about the National Institute of Clinical Excellence criteria. 2 million qualify for bariatric surgery, but it only penetrates 0.25% of the eligible population. We do 5,000 operations a year, woefully inadequate. So BOMS has proposed that over the next year, we increase the number to 20,000 a year, which still only hitting 1% of the eligible population. We have the infrastructure, 40 hospitals, 140 surgeons, and we have a fantastic registry. We heard from my colleagues, Dr. Goyal and others, about the close relationship between obesity, diabetes, and COVID-19 and the poor outcome. So the argument is there. The NHS spends £110 billion a year, of which 10 to 11 billion are just for diabetes care. So we took this argument straight up to the highest seat of power, the Honorable Prime Minister, and BOMS wrote to the Honorable Prime Minister at the end of May when the situation was getting better. We canvassed MPs, and a motion is being tabled in the House of Parliament in the next 4 weeks, looking at what the country would do in terms of tackling obesity. And as you can see, access to surgery figures very strongly here. For our membership, we also produced a reintroducing safe bariatric surgery guidance about prioritization. We heard about prioritization. Of course, cancer trumps bariatrics. But again, compared to all other orthopedics, general surgery, elective laparoscopic surgery, bariatric surgery should be high in the pecking order. So we got a clear document now. COVID-19 specific consent for patients. We heard a lot about preparation for surgery, intraoperative considerations, and postoperative care. And we agree with all that's been mentioned here. Training and trainees, as again Dr. Osman said, is very important, and we need to be mindful of that. And we got a very good registry. So the way we went about it is to create a live reporting mechanism when we reintroduced, and have a daily and a weekly report. Just trying to move my slide again.
You want to double click on it?
Yeah. Yes, I will. Thank you. So the way the audit works is that we have a mandatory data entry within 48 hours of surgery, recording all the inpatient complications, any unplanned admission to critical care, immediately report any unplanned readmission. And most importantly, we added a data field on live recording of 6-week follow-up. And we produced a COVID-19 specific consent form for patients, where patients were fully informed about the chance of contracting COVID during an admission and implications, what could happen to them, including intensive care, treatment, and possible mortality. And this is what the report looks like. So this is from the 26th of August. I printed this out. Across the country, we did 262 cases. And I'm pleased to report that I checked it online this morning, and they have now crossed 500. So in the last 2 weeks, the number of cases have really ramped up. We captured all the ITU admissions, planned, unplanned, for the patient mortality, any mortalities, and I'll come to that in a minute. And there were a small number of cases where the outcomes were not recorded, and we are actively chasing those surgeons and units to make it as close to 100% as possible. And we also looked at both the NHS, which is a government sector, and the private sector. This is a positive outcome of this new audit, because previously NHS cases are mandatory. You need to enter them into the register, but private was kind of voluntary. Now, more and more surgeons and more units that do private work have taken upon themselves to be part of this data. So it's serendipity. It's great. We got a positive outcome. And it's reassuring to note that of the 262 cases, 265 cases, there's a fair sprinkling. Still, people are confident of doing gastric bypasses and sleeves, and also the endoscopic procedures and gastric bands. The length of stay, most patients, particularly the band removals, they stayed just a day cases, and sleeves bypasses within 1 to 2 days. And a small number, due to one reason or the other, stayed a bit longer. But reassuringly, there's been no COVID-19 in these 265 and no COVID-19 in the 502 cases done so far, and no mortality. So in summary, to conclude, we can confidently say that bariatric surgery during the COVID time in the UK has been very safe, and we have achieved this using a standardized toolkit. And you would remember that, I'm sure this is the same story around the world, the multidisciplinary team, which is so crucial. We had been dismembered during COVID. The dietitians were redrafted to do something else. The physicians, the surgeons like myself doing cancer work and emergency work, we got them all back. And when you have a really important game, you put your friend in best players forward. So we have the experienced theatre team. We were very careful in selecting patients, and the specific consent form is what I showed earlier on. The standard operating procedures with no risk approach, maybe occasionally double consultant operating, senior trainees, and we captured all the data in real time and put that forward through the registry, which would be helpful to convince our managers and our political masters. So by doing all this, we have continued to ensure that we provided and will continue to provide the best quality clinical care to this needy group of patients whom we are all really privileged to be able to serve. And I'll stop there and open it up for discussion. Thank you.
Lovely. Thank you very much, Vinod, for that really excellent presentation. Truly enjoyed it. Thank you all the panelists. Thank you everybody who's around here. I see Prof. Vijay Lee also here. So Prof. Vijay Lee, we have not heard from Taiwan. How is Taiwan coping? Because you are probably the earliest ones to recover from COVID and not have gone back to COVID. What kind of herbal medicine do you have which we don't have? What have you done right which we can't do right?
Thank you, Asin. First of all, I would like to thank ELSA for providing APMBSS this good platform for a seminar. And congratulations, Simon and Asin, for organizing this very important symposium. And for me, I must say, I never seen one COVID-19 patient up to now. So in Taiwan, the life is too smooth to provide any experience. So up to now, we don't stop any bariatric operation, and we don't do any screen tests in Taiwan. So it's exceptional. But I know the situation is different from area to area. I have a fellowship from Masari Amuhai from Kuwait. And I realized Kuwait is still in lockdown situation. And up to now, no elective surgery can be done even today. So that is why he needs to postpone 1 year for another fellowship program in Taiwan. So I think in some countries, the situation is still very strict. No elective surgery can be done. And the last experience I have is to travel. I don't believe any guy in here can travel now, but I tried to travel to China for a meeting last month. So now it's quite difficult to travel. I quarantined 14 days in China, and when I come back, I have another 14 days for quarantine. So I read a lot of books. But my personal experience is, if you follow the regulation in your government, the thing is quite, I think, safe. In China, they now starting to do all bariatric surgery, but they screen all the patients. When they admit to the hospital, everybody needs to do a nucleic acid test. If negative, no symptom, they then they pursue all the operation. So now I think life in China also going to a smoothly, no space situation. Yes.
Thank you. Thank you, Prof. Vijay, for that insight. We have Suteb here. Suteb, how's it going?
Yeah, I'm here.
Yeah, Suteb, how's Thailand coping, and what's the state of bariatric surgery in Thailand with the current?
Yeah, Asim, thank you very much. Let me share to all with this graph. This is what happening in Thailand. So as been already informed that the first case outside of China was in Thailand. So we have the first case in January 12th. So it's about 2 months after the first infection in China. Then you will see the curve. It's slowly going up. Mostly for the first month in January would be the imported cases. Then in March, you will see the red bar. That was the worst situation that we're facing, but you can see the number of cases per day. Maximum is 185, which is in middle of March. So this is a phases that we've been facing. So I think at that time it's been very much difficult because we don't know much about these diseases, and also it's been very much difficult to deal with. And then this is what we are doing for metabolic and bariatrics. You will see that for the first phase, for the pre-pandemic, we're still doing bariatric and metabolic surgery. Once the curve is sloping, it's going up, we absolutely stop also visits, including the outpatient and inpatient, also the surgery to protect our obese patients who are on the very high risk for the severe if they got infection. So you see that, but at that time you will see for the whole theater will be 50% of our capacity. We only doing emergency and cancer cases. So we, as me, I'm not doing cancer, I'm not doing emergency, so I'm free from my work. But anyway, we're doing several meeting online. Then you will see that when the curve, yeah, the government and the people here have been done a wonderful job trying to put down the number of cases. Until late April, you will see that the number of cases has been flattened down. So then we start prioritize bariatric and elective cases to be joining for the emergency and cancer. You will see that we call that transitional phases. So we up our capacity of the theater to 55%, and those who are in need for bariatric, we prioritize them. Who are in need, who are hurry for the treatment, we will do them. So that's what we did on that first phase of the resuming of bariatric and metabolic surgery. But those patients have to be under the test for COVID-19, which is the PCR test. And then we have done in our center, in our hospital, which is the main hospital for COVID cases too. So we run the test pre-operatively, and out of 3,000 cases, we have 0 infected cases. So after that, we stop doing the test and we do it electively, only those who are on risk. Then you can see from late May and June, we are back to normal. Yes?
So that I'd like to ask the whole panel one question. Who do you prioritize for surgery? Who do you take the pure obese, the low BMIs, the high BMIs, the super BMIs, or those who are sick with comorbidities? I will just take one line answer from everybody. Kasama, you go first. Who do you prioritize for bariatric surgery? Who in your idea should get bariatric surgery first?
Okay, thank you for the question, Asim. So to tell the truth, I don't have any priorities in Japan. So now, of course, we have to suspend our surgery for a while. But now we restart the surgery. So we don't have any prioritize for our patient.
Okay, thank you. Vinod.
Thank you, Asif. We do have a prioritization document, P1 to P4, which is approved by the Royal College of Surgeons and the Federation of Surgical Specialist Association. Right. P1 is an emergency situation which is within 24 hours, like bleeding or an asthmatic leak. We have included nutritional failure and the opportunity to have revision surgery in patients who are getting more and more malnourished as a P2 criteria. So that can be done within 3 to 7 days. And then there's a balloon removals as well within that period. In answer to your question, we do not operate on the super obese at this stage, but it's mainly the ones who are between BMI of 40 to 60, who are diabetic and who have one other dysfunction rather than failure, like kidney or heart. So
okay, I'll take you, Vinod, on that super obese in a minute. Prof. Vijay Lee, although Taiwan hasn't seen a wave, but if you had come through it, who would you, in your mind, think should have had bariatric surgery first?
The patient I'm most interested in now is young onset diabetes. Yes. Okay. So, yes.
Lovely. Raman.
Yes. So I think with the current knowledge, Asim, that I presented today, yes, I think priority should be limited only to those who are purely obese or purely diabetic. Okay. Those with associated comorbidity, they are the ones who are more likely to have mortality related to COVID in case they get it after surgery. So I think the prioritization document that has come has to be reevaluated with this current knowledge that we have.
Lovely. Thank you. Simon, on your side, you're seeing 3 waves. You are the most experienced among us with COVID. So let's hear from you.
I think I'm agree with Minon that we actually try to operate on everyone, but those who have emergency and also nutritional need, of course, they will prioritize. But we try not to operate on super obese at this moment, mainly for their ICU status and occupying our BC units. So that is one of the exclusion at this moment. But for others, I think obese, diabetes, they are all likely benefits, and we don't want them to wait.
Mahir, one-liner.
Okay, I mean, there is no question about the emergent situation, but I agree that we can operate on anyone who is whose BMI is over 40. In order to save the ICU bed, it is definitely better to avoid someone with BMI over 60 plus comorbid disease such as uncontrolled diabetes, sleep apnea, and cardiac failure.
So now I will just say, I just need a yes or no answer from the faculty on this. Do we believe that if we operate on these obese patients in a pandemic situation, can we bring down mortality, morbidity associated with obesity despite what it is? Simon, you go first.
Sorry, I don't get what your question is. You mean for those who...
with bariatric surgery, we bring the people down in their weight. Do you think we can recover them better? They will have a better chance of survival or not?
I think it always, when you lost weight, you have a better chance of survival from every kind of disease.
Mahir, next off.
Definitely. I mean, there are papers showing that obesity increases the risk of complication with the COVID-19 infection. When we
I'll come back to you on that one.
Yeah.
Vinod.
Well, very definitely yes.
All right. So I think it's a consensus that the answer is yes. Now, my outstanding question to all of you is, what level of obesity attenuates that viral response that me and you are looking for? Because as Raman just presented, that super obese makes no difference. Obese makes difference. So what level of cutoff we are looking at? Because I've got people from the UK who are basically seeing big, huge patients. The Asian continent is seeing relatively smaller patients with severe diabetes. And I've got the Taiwanese group here who are seeing young onset diabetes. So how do we now fit in? Where do we draw that line? Since we know you're on the big screen, let's get you on first.
Okay. I think it's very difficult to draw an absolute line. I think that is where your clinical experience, your judgment, the call of the multidisciplinary team, which is minimizing risks. And also one other factor I'd like to bring in is there are lots of young surgeons, newly establishing surgeons. And if you throw them at the deep end with, complex patients, very super obese, they have one adverse outcome, which could be related or unrelated. It will destroy the service, it will destroy the individual and the profession. So I think we just need to be very careful along those lines, really, that safety is paramount. And there is a certain bit that we can achieve and achieve it well.
Raman, can you take on that question? You were the presenter.
So, Asim, my take on this is that this question is wrong. Because, if you look at oncology, so if somebody has a cancer, and we know that he's morbidly obese and we do a surgery in that situation after diagnosis of a malignancy, then the chances of survival will improve. But still for so many years, it was decided that once a malignancy is diagnosed, bariatric surgery should not be done on that person. So I don't think this is a valid argument to say that we operate on 200 patients in a country and we'll bring down the morbidity of the COVID or in individual or as a group. I think this argument is fallacious. This will have no impact because the numbers can never be substantial as UK study has shown. The number of obesity is increasing because people are locked up in home. So that number will always overtake whatever benefit we have given to society.
My question is about BMI cutoff point. Where do you put your BMI cutoff point? How do you say this degree of obesity I accept and wouldn't expose the patient to extra danger? Would you not use BMI? My question was pertaining to that.
So I will not do on a super obese, obviously. So up to 50, 55 BMI, yes.
Mahir, do you have any differing opinions?
Yes, the rate of obesity and the degree of obesity based on BMI is not useful as you compare the countries all over the world. So in my country, 50 BMI might be equal to 35 BMI in Thailand. I don't know. I mean, the rate of effect of obesity in inflammatory status and the immune system might be different between countries. So I cannot give any rate of BMI for this question.
Thank you. Prof. Vijay, do you agree?
My personal experience in low BMI, I would rather to see the waist and the fat abdominal adiposity. I think it's better in Asian for low BMI patients.
We did some little work on this question, and what we have found out is that once a patient is overweight, his ability to respond to an acute inflammatory state is super high. Once he goes to class 1 obesity, he maintains the effect of the overweight category. But once you go to class 2, class 3 obesity, although the immune system is in a hype, but its ability to respond is very attenuated. So although it is still in a very hyperactive state, it will still be very attenuated. So that was what we found. We've sent the thing for publication. Hopefully it will get accepted and then we will share with you. Well, it's been a great honor to have all of you. Thank you very much for this interactive discussion. I think we are off to the next session. I thank all the panelists, speakers, and everybody. And over to you, Simon. Back to you and Raman.
Yeah, thank you, everyone. I hope that the problem will be soon over, and the vaccine is coming. So everybody get the vaccine and come to Hong Kong, I think.
Oh, sure.
See you all. Yes.
Next year. See you all. Bye-bye.
Thank you so much.
Bye-bye.
See you. Bye.
Thank you. Very good. Very interactive. Thank